I think with John, I have a question for you. I mean, you did some of the work where Rituxan biological activity was decreased in the presence of ibrutinib, I believe. So I was going to ask you what your thoughts on that, because a lot of we're combining ibrutinib with rituximab, but your in vitro studies were very interesting. I thought you could just mention it.
Yeah, I think it's clear that that ibrutinib inhibits ITK, which is important to the NK cell mediated killing by antibodies. How that's going to bear out in the clinic is important. It certainly builds the case for using more selective BTK inhibitors that lack that, or idelalisib, which lacks that in combination. But I think the point with all these combinations is we have to pick them for the right patients, because the attention to risk, I think, is very, very important and really shouldn't be done outside of the context of a clinical trial.
I think to move on real quick, before we move into lymphoma, let's just talk about some of the newer agents. In particular, what's the feeling of the panel on ABT-199, BCL2 inhibitor?
I'm very excited about it. I've been involved in studies with a precursor drug and even a precursor to that drug, navitoclax, which is 263. 199 is a more specific inhibitor of BCL2, and it's an orally active agent, and it really is a drug that seems to target a molecular lesion in CLL. Namely, CLL cells have among the highest levels of expression of BCL2, even higher than follicular lymphoma. And it's one of the features, the molecular features of CLL that's quite distinctive. Now, when you inhibit BCL2, these cells undergo crisis. They can undergo apoptosis in a hurry. So obviously the major problem has been tumor lysis syndrome. It's quite striking, though, to have tumor lysis in patients with CLL, but it can represent a threat. I think the problems with tumor lysis is that it's completely asymptomatic until your heart stops. And so you have to be aware of it, and the patients have to be aware that it can happen. And so there's a need now to formulate a ramp-up dose escalation scheme with close monitoring of the laboratory values to make sure the patient's not getting into trouble. That has really helped. In the more recent studies, the phase 2 studies after some unfortunate deaths with tumor lysis early on, have not shown any major problems with tumor lysis. Most of it's been chemical. I think it's a question of, if you have a high-powered Ferrari and you put it in the hands of a teenager, you're going to have a lot of accidents. But if you put it in the hands of a skilled physician, perhaps you can use it to get places that you couldn't go before.
I think one of the other interesting new therapies at this meeting is divarasib, or IPI-145.
Yes.
And something, unfortunately, it hasn't been very common, but there's in the ibrutinib resistant patients, one of the things that the initial mutation showed is that there was still BCR dependence, and that several groups, Dr. Wang at Cornell, our group, and others have shown that you can inhibit approximately B cell receptor signaling and abrogate the resistance of the ibrutinib mutations. And so there's an abstract, and again, it's not showing more than a base hit, but it's showing that you can give these PI3 kinase delta inhibitors, and IPI-145 is the first in this abstract that's describing this, where you can at least produce a response in a patient to stabilize their disease in the setting of rapid progression on after becoming resistant to ibrutinib. So I think that's going to be an interesting agent, that will follow, likely in the path of idelalisib. Separating the two, I think, is they're a little bit different molecules. But I think we've talked a lot about ibrutinib, and that's another exciting class of molecules that we have coming forward for CLL.
Well, I think also with idelalisib, we have, in addition to that, there are a number of other agents. You just mentioned IP-145, which actually is both gamma and delta inhibitor. But another one is actually, there's a number of agents, a number of companies are working on these agents. And another one, actually, it's interesting, there's some data also at this meeting with TG Therapeutics are working on another agent, similar agent, but with theirs in difference compared to C. It hasn't been directly compared to idelalisib, but what they're indicating is that they're not seeing some of the more common side effects, such as the colitis that was seen, idelalisib, and that the structure is different, the molecular structure is somewhat different.
The liver toxicity.
The liver toxicity, it was
is less.
mentioned in an abstract. So it's just kind of interesting, even though we have an agent targeting the same target, there are differences that might actually have to further refine to be defined.
I'm somewhat critical of
Yes.
that
Okay.
compound, mainly because we know in the mouse model,
Yes.
where you knock out the P110 delta,
Yes.
where you say that you get colitis, you get the autoimmune complications, and so say maybe why they're not seeing that class effect, because you've seen it with every other delta inhibitor, is that it's inhibiting another target, and so I
But
think,
if it works,
but if it works, it works.
it works.
Say,
So,
Well, one thing I think it's going back to 199 that I think is quite impressive for me is that even as a single agent, we've had patients get into complete remissions without any evidence of leukemic cells in the marrow by very sensitive testing. And I personally have stopped therapy of those patients again. And that to me is something that's very impressive, to be able to stop therapy after a relatively short course of treatment. Whether combining this with antibodies, I know trials are ongoing to combine this with obinutuzumab and also with rituximab. And early going, it appears that the response rates are higher when you do the combination, so there may be a rationale there. Maybe combinations of all these approaches might have the ability for us to treat patients into complete remission, and who knows, we might cure a few folks.
I think my only concern with that is that from the data that we're seeing emerging now is that the MRD negativity, a lot of the studies are showing that MRD negativity in peripheral blood actually is actually very significant, and actually that we were talking a little bit before, that one actually trial said that if you are actually MRD, you're a partial remission, right? You still have some residual disease, but you're MRD negative in blood, you actually can do better than a patient who is a CR, actually has a complete remission, but still MRD positive.
There's,
So, I mean,
there's a problem with that, okay? I don't believe assessments in the blood for MRD in the setting of antibody therapy.
Okay.
So in the time of therapy, when a patient's receiving antibody and up to 3 months after therapy, it's only maybe after 6 months or longer when the antibody is completely washed out of your system. Because if you test for MRD negativity in the blood, you're going to have a 50% false negative rate. If you look in the marrow, you'll find cells, even though you don't find them in the blood. So I think that it's okay if the patient's not around antibody therapy, like maybe a year out. Sure. But in the setting of therapy, I don't believe MRD negativity. Now, I think it's very clear to me. We have some patients treated also with the 199 trial where we found no evidence of leukemia cells in the marrow, and yet there was 2 centimeter lymph nodes. So we went after and biopsied those lymph nodes, and we found no CLL.
Fascinating.
I think that's exactly
And that's
what
the issue.
Dr. Chutchman's speaking
Right,
to, is
right.
that the MRD negative
Right.
PRs, so the patient with a persistent lymph node on CT scan is a PR, but their MRD negativity is more predictive of their overall outcome. And
Potentially.
this study, I think, is very important because it's the first time we now have clinical data supporting that.
Yeah, we have the Mediterranean fruit fly in California, and they put up these fly traps because if you had to take a net and capture every fly in a lot of air, you would be having a lot of problems. I think the marrow is somewhat like the fly traps, and that CLL cells has a proclivity to home to the marrow, and if you don't see the disease there, I question what's happening in other sites.
Yeah, I definitely agree that the bone marrow MRD assessment is a much more reliable way of measuring MRD compared to peripheral blood MRD. And I also want to caution that depends on what kind of therapy you're using. The MRD might mean quite different things. So for example, for immunochemotherapies, there are clear data showing that MRD predicts longer progression-free survival. But if you're using immunotherapy alone, for example, alemtuzumab-based therapy, many patients can achieve really good MRDs in the marrow, but yet the progression-free survival is not as long. So it really depends on, and also with the novel agents, for example, the B-cell receptor pathway inhibitors, most of the patients there have a beautiful bone marrow lymph node response, but still have MRD positive in the blood in the bone marrow.
I think
but
that's interesting, yes. I was just going to interject that we do have different components now, different compartments, and what we've taught is that you have your blood, your marrow, and your nodal compartment, we'll say. But what was interesting is that at least in a lot of the lymphomas, we can do a PET scan, and that nodal compartment, that's negative. It's a pretty good indicator it's negative. We do not utilize, at least haven't utilized a lot of CT scans in the past to follow our patients with CLL. But now in the advent of the shrinkage of the, the nodal disease with these B-cell receptor, are you utilizing CAT scans more often?
Well, I think
Patients off protocol or not?
First, I want to say that Dr. Ma's made an excellent point with alemtuzumab,
Yes.
which is really great for clearing the leukemia from the blood and the marrow. But if the patients have large lymph nodes, for some reason, there's no way that alemtuzumab can work. And I would not give alemtuzumab to patients who have lymph nodes greater than 2 centimeters
Sure.
by CT scans for that reason. There may be a reservoir there, and so you can get MRD negative marrow, and then the disease comes back probably from these sanctuaries in the lymph node. As far as CT scans, I remember having a patient come down from Los Angeles, and he brought a stack of CT scans. He was from Hollywood, and I told him he has to get away from the radiology paparazzi. But it was the kind of thing that he was coming in every 3 months, getting CT scans, and it was to obviate a clinical exam, and you had a nice record. This is ridiculous in my opinion. One thing about CLL, it's probably the most metastatic disease on the planet. It's in every lymph node, and so by feeling and evaluating the peripheral lymph nodes, one gets a good evaluation of what's going on inside. I've very seldom been surprised.
Yeah, but this individual with the CT scans, could you consider that low-dose radiation therapy because there's exposure to radiation there?
Well, there you go.
You know?
That's another modality we haven't talked about today.
I do, so with the 2 issues that we have now before us,
Yes.
I do want to add with the MRD negativity, it's sort of a nice potential future way to sort of help obviate the need for CT scans, because I do believe avoiding CT scans is very important for patients and adds very little to the care of a CLL patient outside of a clinical trial. So I do really try to avoid them as much as possible.
I really don't think you even need them in clinical trials. If you do a good exam, you study the blood in the bone marrow compartment. There have been several studies. The Germans have done a study. We've done a study. CT scans really do not impact the response on a CT scan over an exam. Doesn't impact progression-free survival or overall survival with targeted therapies or chemoimmunotherapy.
I think this is true, and I'm very tired of this need for CT scans that many of our current trials are putting us through. They claim it's due to the FDA, but I think it's just also a penchant for trying to get as much data as you can because you're looking for that little shrinkage to get your hopes up. So I really think I agree with the panel that CT scans, I think, are overused in CLL.
With these clinical trials, there's this new endpoint that's emerged, which is time to response. And I think that that's very problematic as an endpoint because it really is not that important to the patient. And what really is most important to the patient is going to be overall survival or progression-free survival as a surrogate. And that's something that the CT scans really don't add much to. I do just want to add something about the MRD negativity, and I think it's a very interesting feature with these B-cell receptor antagonists, and it's really become a much higher bar. And MRD is studied in very specific situations. So we look at FCR chemotherapy, we look 2 months post-FCR chemotherapy, and we can help predict the overall outcome. I'm always very cautious about prognostic markers being used after you've delivered the therapy. So if you're not going to be able to use that prognostic marker to decide what else you need to do, then there's no reason to do it. And with the MRD assessments in the B-cell receptor antagonist patients, because these cells are preferentially circulating now because of the inhibition of adhesion molecules, it really makes it a higher bar. So the example I like to cite is that if you were to take a patient who is MRD negative 2 months after 6 cycles of FCR and give them ibrutinib and they were to become MRD positive, is that a bad thing? I mean, the answer is you're giving someone what ostensibly is consolidative therapy and mobilizing the cells. And I think it just really speaks to the fact that it really is important to use the MRD in a way that's going to be useful and helpful to the patients.